ahead and introduce the keynote address speaker for this meeting. Our keynote address speaker is no less a person than Dr. Kyriakos Stylianides. I've taken time to learn how to pronounce this name, and I hope I got it right. Dr. Kyriakos Stylianides has been practicing palliative care in Cyprus since 2006. He graduated from the Ovidius Medical University of Constanta in Romania in 1999. And from 2000 to 2001, he worked as a junior doctor in the Bank of Cyprus Oncology Center in Nicosia. And between 2006 and 2018, he worked at the supportive care unit of Bank of Cyprus Oncology Center as a palliative care doctor. During this time, he did several courses in palliative care, including Essentials in Palliative Care from Prince Alice Hospice, Communication Skills course, and 2 months fellowship in San Diego Hospice. From 2015 to 2017, he studied for a postgraduate degree in hospital management at the Open University of Cyprus. And in November 2017, he was awarded the Baschelor degree of Health Units Management. Since November 2018, Dr. Stylianides has been employed at the Pan-Cyprian Association of Cancer Patients and Friends as the medical director. In March 2019, he spent a month in Ohio State, where he was trained in palliative care for children. And he's been providing services for palliative care patients through Cyprus National Health System, and both hospices are directed by him. Dr. Stylianides lectures 6th-year medical students in palliative care at the Cyprus Medical School. He participates with ASCO as a facilitator in education for palliative care around the world. He has participated in several master classes for palliative care, both in organizing the master class and as a key presenter and facilitator, both in Cyprus and abroad. Dr. Stylianides played an important role in establishing legislation for palliative care in the island of Cyprus. He convinced the Ministry of Health that palliative care should be part of the national health system, and it should be offered to adults as well as children from the beginning of their diagnosis. His main goal was to make palliative care available for all the patients that needed it all over Cyprus. Dr. Stylianides is the first doctor registered as a palliative care physician in Cyprus National Health System. Ladies and gentlemen, colleagues and participants around the world, please join me in welcoming our keynote address speaker, Dr. Kyriakos Stylianides. Welcome, sir.
Thank you very much. Thank you very much, Gwyneth, for all your nice words. I'm very honored, and I also feel privileged that I'm given the chance to talk about palliative care, not only in my country, but all over the world. And I felt very excited when Dr. Nathaniel Soro asked me if I could give a talk about the ethics that are raised when we are dealing with palliative care of our patients. And it's something that, unfortunately, in the modern world, we don't pay so much attention. And I feel that after I give my speech and I present you a few things, you will understand how important it is that we should always consider the needs and the what our patients want and not about our needs as providers and not what we wanted. We should pay more attention to the needs of our patients. So by saying that, I will share my screen. So what we will talk for the next half an hour, it's the ethical requirement in oncology for palliative care. I have a short film, which I think it will give us an understanding why it's so important to consider ethics when we are talking about palliative care.
One of the things we want to bring around the end of life is dignity. We want people to die with dignity and quality of life. If you talk to anybody who have lost a loved one, the greatest regret people have is that I wish I said goodbye. I wish I spent 10 minutes with my dad and told him how wonderful he was. And I regret that personally because my dad passed away in great pain. His pain was not controlled, so he died in a lot of pain. And there was no opportunity. He could not even comprehend who was there with him when he died. And I think that is a regret for all of us. When we lose our loved ones and they're in so much pain, they're wailing and screaming, they did not even know you were there. So it's just providing that dignity and an opportunity for people to put their business in order. Because at the end of life, your value as a human being does not stop.
Many people ask, what is palliative care? I see it simply as therapeutic interventions to try to relieve and even prevent issues that cause suffering.
Palliative care is whole person care.
To try to avoid pain, or when it starts, to manage it well, to deal with many other symptoms that I might experience.
It takes seriously physical, psychological, social,
Anxiety, depression, challenges within my family.
existential, spiritual, financial issues.
Spiritual questions. Why me? Where's God? What about the meaning and value in my life?
It recognizes the profound importance of Sisley's term, total pain.
To help me manage the advancing illness as I approach the end of my life, to help me prepare for the end of my life, and specifically to manage all of the issues that arise during the dying process so that I can feel as comfortable as possible and have a safe transition as I die.
Whole person care is a central concept, but the foundation of the edifice of whole person care is excellence in physical care, good nursing care, good, knowledgeable, available medical input. This is not a place for amateur night. These are the sickest people in the healthcare system. They deserve the best care.
Between the hospice people and my doctor and the others, the nurses, specialists, they've turned me around so that I can sit up and I can, it's a marvelous thing.
Thanks to them, we have, my mother has had more days when she is comfortable. And when she's comfortable, we can laugh and joke and have meals together and just kind of treasure this time together. And without them, it would probably be a much different situation.
We have this wonderful profession of hospice and palliative medicine that is an international profession. And so people don't have to go through this alone, that there are experts that can help them to walk through this and that people do not have to die in pain.
In an age where we're doing such wonderful things in all specialized areas, to then bring amateurism to the sickest people in the healthcare system, it's ridiculous, particularly when we know how much that we can achieve, how helpful we can be.
So when we are talking about palliative care, we have to think that it's a human right for people not to suffer. And I was doing some research also for Nigeria, and we see that there are approximately 100,000 new cases of cancer every year. And these patients, unfortunately, they present at an advanced stage of the cancer when the only treatment options remain is palliative care. And
excuse me, please permit me to interrupt. Kindly swap your display so that right now we are seeing presenter's view. So you can click on either swap displays or use slideshow.
yeah, okay. Yeah, thank you. Thank you.
Okay, you're welcome.
So we see that in USA, causes of death is the first reason for people that they die in the USA, with which is very close to the first reason, which is cardiac disease, is malignant neoplasm. And then the third reason is by far much less. It's only 150,000 in the USA, and that was a research done in 2004. So you understand that controlling the symptoms, it's our obligation for our patients. And usually the main symptom that our patients have, patients with cancer, is pain. And you can see that the percentage is very high. 84% of those patients diagnosed with cancer, they will have pain. And of course, they lose their appetite, and that's also a very high percentage. And another important problem is the breathing and nausea and vomiting. So all these issues need to be addressed in order to have a better quality of life. Palliative care in most African countries is rudimentary, and most health practitioners have poor knowledge of palliative care. It has been shown that established care, support, and pain control exist only in a few African countries. Nigeria, thank God, is one of them, and it's advancing quite a lot. As clinicians, it's our obligation and duty to ensure the well-being of our patients. Physicians must protect the lives of their patients and should never hasten their death. When we cannot cure an alignment, what we have to do is to relieve suffering, but never abandon the patient or initiate terminating their life. We must promote palliative care and give both psychological support and social support so they can find the meaning of life until the end of their life. The mother of palliative care, Cicely Saunders, which she was a nurse, she started as a nurse. She worked very closely in the Second World War with the soldiers that they were dying. And she found out that not only they were in pain at the end of their life, but they wanted this support, the psychological support. They wanted to send a message to their loved ones. And she was the first person to realize the need and the meaning of palliative care. It was very late. If you see that it was only in 1959 that she described in a nursing article about the palliative care and ethics. And only in 1979, there was the principles of biomedical ethics and the respect for autonomy, non-maleficence, beneficence, and justice came into the field. In 1987, I was very late still, palliative medicine becomes a medical specialty in the UK. So it took very long time until we decide that we need palliative care for our patients. And hospice and palliative care recognizes that medicine was failing the dying. So at the end of their life, we didn't do much. We had a bad response to the bad death. Nurses were pioneers in hospice care. And as we said, Cicely Saunders, she was the first one to address the issues about palliative care. And then the medical ethics recognized that medicine was failing the patient, the right to self-determination, autonomy, and patient's rights rather than doctor knows best. And in my word, unfortunately, this story is something that we see quite very often. We don't allow our patients to choose how they will be treated. We make their decisions, and this is very wrong. It leads to paternalism, which is very wrong, and we don't respect the rights of our patients. So the core medical ethics is all about autonomy, which is the most important thing, and the patients, we have to empower our patients because they have the right to refuse any treatment, or they can choose what kind of treatment they want. It's about beneficence, always acting in the best interest of the patient. And non-maleficence, above all, do no harm. Justice, fairness, and equality as to who gets what treatment. All patients are the same and they have the same rights. And of course, never forget dignity. We should treat our patients, family with respect. And fidelity, notions of loyalty, commitment, and trust in the relationship. All these are very important when we're talking about ethics and palliative care, and we should always consider them. Autonomy is about the individual, sovereign self with positive and negative rights, free from interference, and the right to determine one's own life. Our patients are asking us all the time to let them make their own decisions. It's about their life. It's not about our life. And these decisions can include any of these, whether it's treatment, whether it's to resuscitate, to sedate, to go home to die, to refuse morphine, to want better symptom control. Our choices, as Cicely Saunders says, do not take place in a purely individual setting, guided by the principle that life is of value until its natural end, with space for mending relationships and honoring important values by competent, ever-improving care. Believe we should constantly reiterate that this is the way to respect patients and families' true needs. Their autonomy must be seen in the context of society as a whole. And then palliative care came, which is specialized medical care for people with serious illness, like cancer patients. It is focused on providing patients with relief from the symptoms, such as pain, stress of the serious illness, whatever the diagnosis is. The goal is to improve the quality of life, both for the patient and the family. And there have been a lot of changes in palliative care over these few years. It's the active management of a progressive chronic disease and not only malignancy. From palliative care to palliative medicine, we have progressed to this, which means a greater willingness to actively manage disease using medical methodologies, upstreaming palliative medicine to earliest point in the diagnosis of progressive disease. The earlier it's applied, the earlier palliative medicine is applied, the better quality of life our patients will have. There were ethical conflicts involving the principles of autonomy, beneficence, non-maleficence, and justice. The decisional capacity, it was a main problem because the majority of patients, they lose the decisional capacity. Advanced directives. Do you have a healthcare proxy, somebody who can make decisions for you in case you cannot make these decisions? Truth-telling, are we obliged to give the prognosis to our patients if they are asking for it? And informed consent, family asks you not to tell. Something, again, very common in my world, that usually a son, a daughter, tells us doctors, do not tell my father what's going on, do not inform my father that she's dying. Are we allowed to do that if our patient is asking for information about his prognosis or his disease, how it's going to evolve? Factors impacting on ethics in palliative care: the rapidly evolving medical technology. People, they live longer now. The advances in medicine are a lot. So this longer survival, it means that there is increasing burden of disease and functional impairment. There are polarized and scrutinized political and medico-legal environment. And also we should consider the awareness of cultural, religious, ethnic, economic, educational, and other diversity. Applying the ethics now to a clinical setting, it's always a medical decision-making. We should consider issues of utility, conflicts of value, patient, family, doctor, nurse, and best interest, realistic goals of care, the level of suffering, and the quality of life that the patient will find acceptable, not that we will find acceptable. It's all about our patients. And we should try to restore the balance, because providing a proper and a good palliative care, it means a life-prolonging care. Of course, the potential goals of care is to cure the disease, but at the same time, we should relieve the suffering. We want to avoid premature death, but we should consider the quality of life. Maintaining or improving function, it means also good health, staying in control, and this will prolong life, of course, but at the same time, we need to support families and loved ones. Palliative care focuses on relieving suffering and to improve the quality of life, affirms life, sees death as a personal and natural process, appropriate early in course of an illness, patient and family preferences are always respected, and maybe, of course, combined with curative therapies or maybe the focus of care. It is an interdisciplinary care of the patient and family. Pain and symptom management may include disease-modifying treatments. It's all about psychological, social, and spiritual support. And of course, never forget that it's not only the patient, it's the family, and we have to consider the bereavement support after death for those that are left behind. Objectives is how and where we are dying, explain what is palliative care to our patients, setting the goals of care, delivery of palliative care, explain what is hospice, advanced care planning, and I want to explain a little bit about this because it's very important. Unfortunately, we are still, even in my country, we haven't progressed in planning how we'll proceed after we are with a serious illness. And this is a very important thing because we plan for future medical care in the event a patient is unable to make own decisions. And this should be updated regularly according to the course of the disease. What are the values and goals? Designate surrogate the decision maker in case we are not able to make our own decisions. Remember that this is a process and not an event, and it helps a lot because it reduces confusion and conflict. Ethical guides for treatment choices. All treatment decisions are made in context of person's values, diagnosis, prognosis, risks, and benefits of any treatment option, whether he chooses no resuscitation, no dialysis, uses of mechanical ventilation and antibiotics. This should be the patient's decision. Withholding and withdrawing a treatment are based on the same ethical principle of beneficence and consideration of risks, benefits. Double effect, the intent of the treatment is to relieve X symptom. The dose of medicine did not kill the patient, it's the disease that killed the patient. The four topics, for the unessential structure of an ethics case is the medical indications, which is diagnosis and therapeutic interventions to evaluate and treat. What are the patient's preferences, choices of patient or the person who makes the decisions about all treatment and all options? Quality of life, very important. And what is the quality of life after the treatment that the patient would like to have, and if this is possible. And contextual features identifies the familiar, social, institutional, financial, and legal settings. Medical futility connotes inappropriate rationing, connotes worthy versus unworthy, and connotes decision based on financial only. And this is not beneficial care, and we have to change it on to beneficial care, which is based upon understanding context of this person's illnesses, experience, and values. Is based on knowledge of the diagnosis, prognosis, and risks or benefits of treatments, and uses ethical principle of justice as part of the decision. physicians, nurses, and patients and families are all engaged in making these decisions. We have also, there are issues of dissatisfaction from nurse or physicians because the patient is not involved in treatment decisions, and this should change. Concerns about burdensome treatments, disagreements over withholding or withdrawing treatments, and there is also conflicts between nurses and volunteers when there is no good communication, confidentiality, conflict of interest, and compromised care. Communication between all people involved, whether it's the staff or the patient and family, the physician with the patient and family, physician with the nurses or other health providers, physician to physician, sometimes language barriers, and inadequate discussion with the patient regarding treatment goals and expectations, degree of suffering, and measure of success. From all these there's an emerging ethical issues, and this is the resource allocation, not enough staff to provide palliative care, lack of bedside time, lack of time for quality communication, level of care, withholding, withdrawing treatments, and competencies in palliative care skills like communication skills, understanding of euthanasia, palliative rather than terminal sedation. And after many years, we decided that we should never call it terminal sedation, it's palliative sedation, because we are proceeding to control symptoms that we cannot control with any other medicine or any other way. That's the only time that we use palliative sedation. We should also consider cultural and religious issues related to dying persons, power issues, pain and symptom management, balance of patient choices, and family needs and choices. Mandating palliative care is very important at the end of life. Capacity determination, withdrawal and withholding of life-sustaining treatments, artificial nutrition and hydration, and blood transfusions. Any of these that are not necessary, they should never be applied at the end of life. The New York Palliative Care Information Act, which was effective since January 2011, requires healthcare practitioners caring for a patient with a terminal illness to offer information and counseling to patient or surrogate on available options for palliative and end-of-life care. Determining capacity is a specific issue. We have to understand the risks and benefits of prescription options, deliberate and evaluate in accord with personal values, and communicate his or her choice. Reassess for each decision. Capacity, have in mind, is different from competency. In absence of a healthcare proxy, permit surrogate to make healthcare decisions based on patients' no wishes, or if not known, in patients' best interest. The hierarchy in these decisions is the guardian, which could be a spouse or a partner, an adult child, a parent, a sibling, or a close friend. Limited treatment at the end of life. All patients have rights, even if incapacitated. They have the right to refuse any intervention. Withholding, withdrawing is not homicide or suicide. Orders to do are valid. Courts need to be involved most of the times, unfortunately. Withdrawal or withholding of life-sustaining treatments. Legally, there is no difference between withdrawal versus withholding of life-sustaining treatments. However, psychological, emotional, or religious constraints may exist for family. Legally required to do everything. Unfortunately, it's something that also exists in my world and in many parts of our world. We should consider if withdrawing or withholding, if it constitutes euthanasia. This is, of course, not the case. And we are not killing the patient if we remove a ventilator. We just allow the course of the disease to take its natural course. And we have to explain, and we have to change this attitude that the use of opioids to control symptoms at the end of life is a euthanasia. Opiophobia, it's a major issue all over the world, unfortunately. What is the patient's good? If medicine takes aim at death prevention than at health and relief of suffering, if it regards every death as premature, as a failure to today's medicine, but avoidable by tomorrow's, then it is tacitly asserting that its true goal is bodily immortality. Physicians should try to keep their eyes on the main business, restoring and correcting what can be corrected and restored, always acknowledging that death will and must come, that health is a mortal good, and that as embodied beings, we are fragile beings that must stop sooner or later, medicine or no medicine. Palliative care is guided by patients' goals. Advanced directives clarify patients' goals of care. Setting clear goals guides the direction and plan of care and minimizes ethical conflicts. Hospice is a way of delivering palliative care. Palliative care should be introduced early in the course of life-threatening illness and is compatible with curative care. Conclusion, palliative care is mandated in advanced stage incurable cancer and other terminal chronic illnesses. The different aspects of palliative care, such as pain and symptom control, psychosocial care, and end-of-life issues should be managed in an ethical manner. The cardinal ethical principles to be followed are autonomy, beneficence, non-maleficence, and justice. The palliative care experts and team members should carry out their responsibilities with honesty and dignity. Suffering due to unrelieved pain and unavailability of morphine are recognized as negligence of human rights. There are practical, ethical challenges which need to be resolved. Truth-telling, place of care, continuity of effective palliative care till the last days of life, confidentiality, unnecessary use of antibiotics, nutrition, blood transfusions, and advanced directives can be the key points which confront a palliative care team. The delivery of palliative care and medical ethics are complementary, and use of the two together maximizes the protection and satisfaction available to the vulnerable patient and family members. Palliative care is not about death, it's about life. I would like to thank you for paying attention, and I'm showing you two beautiful photos from the Troodos Mountains in Cyprus, which is in winter time when there is snow, because we do get snow also in Cyprus. Thank you very much for your attention.